All right, today we're going to dive deep into a really critical emergency drug, calcium gluconate. This is one of those meds you absolutely, positively have to know inside and out, whether you're taking care of a patient or just trying to ace an exam. So let's get right into it.
So, to kick things off, I want to start with a question, kind of a paradox, that gets right to the heart of what makes this drug so fascinating. How in the world does giving a patient more of one electrolyte, calcium, become the life-saving treatment for a dangerous excess of another one, potassium? I know it sounds completely backward, but I promise, by the end of this, it's going to make perfect sense. Okay, first up, let's cover the basics. What exactly is calcium gluconate, and what are its main jobs in the hospital? Getting this foundation right is totally key to understanding everything else that follows.
At its core, it's pretty simple, actually. Calcium gluconate is a mineral and electrolyte replacement. Its main mission is just to give the body back a critical substance it's running low on, the calcium ion. That's it.
So when do we actually pull this out of the med cart? Well, its official, FDA-approved job is to treat acute symptomatic hypocalcemia. That's when someone's calcium levels get dangerously low. But honestly, where it gets really interesting is in its common off-label uses. It's an absolute game changer for treating high potassium or hyperkalemia, especially when you see scary changes on the EKG. And get this, it's also the direct antidote for a magnesium sulfate overdose.
So that brings us to the really cool part, how it actually works. And the how for calcium gluconate is really a tale of two totally different mechanisms. Which one is at play really just depends on why you're giving the drug in the first place.
And this slide just lays it out perfectly. On the left, for low calcium, the mechanism is super straightforward. It's just direct replacement. You're simply topping off the body's calcium levels. But on the right, for high potassium, its role is way more profound. See, high potassium makes the heart muscle cells really irritable and twitchy, pushing them closer and closer to firing uncontrollably. Calcium doesn't lower the potassium at all. Instead, it acts like a cardiac shield. It raises the firing threshold for those heart cells, basically making them less sensitive to potassium's toxic effects and calming the whole situation down.
This quote really just says it all. I want to repeat it because it's just so critical. Calcium gluconate has zero effect on the actual potassium level in the blood. All it does is oppose the dangerous effects that high potassium is having on the heart. It's a bodyguard, a protective measure, not a cure for the potassium itself.
So, now that we know what it does, let's follow its path through the body. We're going to look at the pharmacokinetics, how it gets in, where it goes, and how it gets out.
The journey is pretty straightforward. First, we give it directly into the bloodstream through an IV. From there, it spreads out, and most of it actually ends up stored in our bones. Now, metabolism is kind of unique here since calcium is an element. It isn't broken down by the liver like most drugs are. The body just uses it. And finally, it leaves the body, mostly through the stool and the rest in the urine. Now, because we give it intravenously, the effect is immediate. The second it hits the bloodstream, it's working, which is exactly what you need in an emergency. But, and this is a huge but, these effects are temporary. That protective shield only lasts for about 30 minutes to maybe 2 hours. That gives you a critical window of time to start other treatments to actually fix the underlying problem.
Okay, this brings us to what is, without a doubt, the most important section, the critical warnings. These are the red flags, the absolute must-knows for anyone who is ever going to give this powerful medication.
We're going to frame this as 3 lethal mistakes to avoid. And I'm not being dramatic. Getting any of these wrong can have devastating consequences for your patient. So let's break them down.
Mistake number 1. Completely ignoring if a patient is on digoxin. See, calcium and digoxin have a synergistic effect on the heart muscle. So if you give IV calcium to a patient on digoxin, you can amplify its toxic effects, seriously increasing the risk of deadly heart rhythm problems. The takeaway is simple. You always, always, always check for digoxin used first.
Mistake number 2 is giving it too fast. Pushing IV calcium can literally be deadly. A rapid infusion can cause a dangerously slow heart rate, other arrhythmias, and even straight-up cardiac arrest. This medication has to be given as a slow, controlled infusion. Seriously, speed is your enemy here.
And mistake number 3 is a bad IV, what we call infiltration or extravasation. This is when the IV slips out of the vein and the drug starts leaking into the surrounding tissue. Calcium is incredibly caustic, meaning it just destroys tissue. And infiltration can cause severe tissue death and sloughing. This is why having a good, reliable IV line is totally non-negotiable.
Beyond those big 3 mistakes, you also have to know what you can't mix it with. Never, ever, ever mix calcium gluconate in the same IV line with sodium bicarbonate or anything with phosphate in it. Why? Because they will immediately bind together and form a precipitate, like a solid, chalky substance. Not only does this make the drug totally useless, but trying to inject a solid into someone's vein can cause a life-threatening embolism.
All right, we've covered the science, we've covered the scary stuff. Now let's translate all of this knowledge into what we actually do at the bedside.
I want you to think of this as your pre-flight checklist. Before you even think about giving the drug, you must check the latest calcium and potassium labs, you have to ask about that critical history of digoxin use, and you have to get the patient hooked up to a continuous EKG monitor. And then after you give it, your job is not done. You've got to watch for signs of too much calcium, hypercalcemia, which can show up as lethargy, muscle weakness, or constipation. And of course, you're going to recheck that calcium level.
So here's a look at the standard adult dosing for these big emergencies. As you can see, the dose is actually the same for both low calcium and high potassium with EKG changes. It's 10 milliliters of a 10% solution. But the key difference here is the infusion rate. For low calcium, you give it slowly over 10 minutes. But for a life-threatening high potassium situation, you give it faster, over 2 to 5 minutes, because you need to stabilize that heart as fast as possible.
Okay, here's a little real-world curveball for you. If you go digging in the pharmacology books, you'll find that sources actually disagree on the best IV fluid to dilute this in. Some will say use D5W and avoid saline, while others say the exact opposite. So what does that mean for you? It means the #1 rule is you always follow your specific hospital's protocol. Whatever they say, that's the law of the land.
All right, let's boil all of this down into that one single, most important takeaway, the clinical pearl that you should never, ever forget.
Here it is. If you remember one single thing from this whole talk, make it this. In the setting of hyperkalemia, calcium gluconate is cardioprotective, not potassium reducing. Its only job is to shield the heart and buy you time. It does absolutely nothing to lower the patient's potassium level.
And that leads us to our final question. Knowing that calcium is just a temporary shield, what other therapies do you need to be starting immediately to actually lower your patient's potassium and fix the emergency for good? Thinking about those next steps, well, that's what separates good clinical practice from great clinical practice. Thanks for tuning in.